Welcome to Stirring Strength, Perspectives on Mental Health and Addiction. I am your host, Dean Anderson, and on today's show, we have a couple of wonderful people who are working here in London helping with eating disorders. We have Dr. Robbie Campbell, and we have Sarah Bradbury, and you are both from the Harbour. Thank you for being on the show today.
Well, thank you for having us.
We're very grateful that you're here. We have yet to have somebody, we've been doing this show under two different banners for the last 5 years, and we have yet to have anybody talking really in depth about eating disorders from a clinical perspective. So I was really excited when Sarah reached out to be on the show, and then when you asked to be on the show as well, Dr. Campbell, I thought what a great opportunity to get some understanding of this. So what I'd love to do is for each of you to kind of just have a moment to just talk a little bit about what it is that the work is that you do. Do you want to start, Dr. Campbell?
Sure, I can start this out. Well, a year ago, we opened the Harbour, and the design of the Harbour is for students who are suffering or working through an eating disorder and attending college or attending university or even out in the community waiting to do so. So we felt that it would be very important to set a clinic up on campus, so to speak. So we've selected a location, Research Park. And so this is where we've opened. And already in the first 11 months, 12 months, we've had 48 referrals.
Wow.
So we think this is just an indication of the number of people that we can be seeing out there. And the other thing is we are connected with the Student Health Services at Fanshawe and the Student Health Services at Western. And we work in conjunction with those family physicians as they go through school and set up being here for the 3 to 4 year period.
Wonderful. I have a plethora of questions, but first I'm going to ask Sarah if you missed anything. Did Dr. Campbell miss anything?
I think just the important part to remind people is that we are of a theory of early intervention. So it's different than the typical hospital model. We want to catch people prior to diagnosis as well. So they don't require a diagnosis to receive our services like traditionally you'd need.
Wow. That's fascinating. And that makes sense in the student bodies and in the younger population.
Well, it does, because we want to set up, it's kind of a prevention model, right? Because following COVID and looking at social media and all this kind of thing, eating disorders have actually escalated. So there's estimates as high as 40% of the student body has difficulties with eating. Not necessarily a diagnosable form of eating disorder, but in the student population, approximately 13% of people have a diagnosis of eating disorder, and it's below the radar. People are still frightened to come out with it because there's still a stigma attached to it.
That's those are some fascinating numbers. Could either one of you be comfortable with kind of giving a quick definition of how do we determine eating disorder versus early warning signs, or like is there like a line or a tipping point that says this is now a disorder versus a...
Actually, if we look at it and stand back, it's on a spectrum like everything else.
Yeah, okay.
So you can pick up the early signs, and if you get it early, you can go on so that you can help prevent it escalating. So just to give you a quick definition, we're looking at like 3 major categories, but they're different forms of eating disorder.
Okay.
So the anorexic is those people who are restrictive, they're over-exercising, their weight is down, they have a low BMI, and they get dangerously low in terms of weight to the point that they have a high mortality rate. So we have to be cautious. The mortality rate from the physical complications as well from suicidal thinking, this kind of thing. So there's that section, the very low weight, low BMI. Then you have the bulimia. Bulimia is where you're taking in food and you might eat large quantities, you might bring it up, you might take laxatives or use psychostimulants or diuretics, these kinds of things to try and supplement weight loss. So those things are utilized by the bulimic population. Now, there's a bridge. Sometimes you go through an anorexic period, sometimes you go through a bulimic period. But the one thing that people usually forget is binge eating disorder. So this is the precursor to diabetes, etc. So your weight, you can overeat, and you can't control it. You eat until you're uncomfortably full. It's just a horrible feeling, and the guilt associated with it, and you utilize that to try to deal with life's issues. So we're dealing with that is the general kind of spectrum that we're looking at.
Yeah.
So we want to deal with all those things. They're each dealt with a little bit differently.
Yeah.
So we set up a program designed for each person who comes in. But it's not that you put a person in this category, that category, that category. It's putting in and looking at a person as an individual. We are trying at the Harbour to set up an approach for people that's customized, because one size does not fit all. You can't put someone into a program and expect them to adhere to the program. You have to have a person and make a program fit around that person with a multidisciplinary team.
Sure. Sarah?
Yes.
A big smile, yes. All of these things that's being shared about the different types, answer, if you don't mind answering a question, in the role that you play, which is?
I do therapy sessions as well as like public speaking on campus. Okay. We're looking at doing some public speaking in high schools to get some more awareness of eating disorders, and to kind of get rid of that fear of might have an eating disorder, but I don't know if I should go get help. And we want people to say, it's okay, accept that like this has happened to you, and get help sooner.
So what you're talking about is the understanding of the unique perspectives of individuals, and then Sarah's helping with the advocacy and the awareness and the knowledge to transition people into figuring out for themselves.
And she's an integral part of the program in terms of helping navigate the role. So, for instance, an eating disorder, people have focused on just trying to treat an eating disorder symptom without treating the whole person. Because there are things like depression, things like anxiety, OCD, ADHD, substance use, ADHD, autism, these kinds of things that go along with the eating disorder, and they have to be addressed. Sarah is an integral part of trying to help us coordinate the appropriate team to address those specific issues.
And I also do the therapy sessions as well. So.
Awesome.
Yeah.
Awesome. Good for you. Good for you, because those are a lot of heavy topics you're talking about, the concurrent disorders.
These are huge. And not to forget PTSD is part of the component as well, so we have to deal with that. And so we have to set up an individualized program for people. But also, Sarah helps us set up when we look at support groups, an art support group, a music support group, an eating support group, all those different kinds of things. And she's instrumental.
Wonderful.
Yeah.
Wonderful. I'm excited. I even when we're done here today, we have to keep talking, right?
Yes.
Because we live in the same world professionally. You know, There's a big crossover there. So I'm excited to learn more about it. But I got to be careful to keep on my TV show host hat instead of my clinician hat. So based on all of this information, it sounds like it's really more complex than people might think. And there must be some myths or some misnomers, some things that people think that it is when it's not. Is there anything that stands out to you that you mentioned the word stigma at the beginning. So that's normally, where stigma lives. And I'm curious if there are miscommunications or ways that people approach this.
Yes, you hit the nail on the head, because that comes at it from many different directions, including teaching people of how to deal with eating disorders. Okay. So that's not done properly. As a matter of fact, I had somebody because, we've been told to stay away from eating disorders because they're so difficult. The difficulty with is the word complexity that you said. It's a very complex disorder, and it's a serious mental illness, and people don't accept that. We're always invariably getting, well, just eat or just don't eat. What's the issue? Something's wrong. They don't get all the other parts that are going on in a person's mind to try to cope, and they don't understand how to approach it. And invariably, they approach it that makes matters worse rather than better. So we have a role in not only teaching parents, but in teaching other students to be more accepting, but also in teaching teachers and those that are involved in the different disciplines. So we're trying to set up and arrange a multidisciplinary teaching center. And hopefully, in the long run, we'll be able to set up a center of excellence.
Center of Excellence. I love it. I love it. And your enthusiasm while saying it is I am beside myself. I'm excited for this already. So the goal is to work towards a center of excellence. Tell me briefly, what does that mean?
It means that it's funded. So if you look at a center of excellence, then there's the research component, there's the education component, there's the treatment component. So already we're beginning to work with Western researchers, et cetera, trying to set up a research in different areas to move forward in this regard. And a center of excellence involves like a chair. So we'd be looking for a chair to look after that and monitor this, where it's basically a teaching center and research center. So the Center of Excellence would help us look at setting up the model that we have, because it hasn't been done before, to be able to set it up in other centers. So we were trying to set up a transportable model. So, and this is a shared care model, working with family docs, psychologists, social workers, nurses, dietitians, occupational therapists, physio, etc. The whole gamut.
Takes a village.
It takes a village. It takes a team. It's teamwork. And things in the eating disorder world have not been done as part of a team. And we're hoping to look at this whole aspect. How do you train a team to work together? How do you train a team to work with the student, with the client or the patient? How you train them to be ahead of a team and monitor their own team with help.
Sure. So I see the need for all of these people to come together and work together and share their knowledge and wisdom. But it's the Center of Excellence, it sounds like it's also looking at the past and studying the present and how do we evolve to the future. So it's like a moving it forward in a way.
You've put that well. That's exactly what we're looking at.
Wonderful. Now, in doing this, you're working with research, and you've got all these different modalities coming together. What has been maybe any blind spots, anything that you're like, hey, I wasn't expecting to get pushback from those people? Because we know when we start going interdisciplinary that there's things where they have different modalities and different thought processes, and trying to get people to come together is not always easy.
It's not always easy. The thing is, how do you coordinate this? And how do you raise the funds to be able to establish this? So here we are, we're trying to set all this up. We're starting to get buy-in from all the different factions, but we're still strapped in terms of we have to raise money. So we're trying to go on a model where 50% is covered by the student or their parents or their insurance companies, etc. 50% we're trying to raise through donors and sponsorships. As a matter of fact, we're having a big fundraiser on October the 30th at the London Music Hall.
Everybody hear that?
Raise money.
London Music Hall, October 30th, fundraiser.
To raise the proper money.
Yeah.
To be able to set the ask is basically, to operate this effectively, you should have a minimum of $1.2 million a year to try to get it in point to expand.
Is that it?
That's what we're going to need. That's it, because we can capitalize on different things. But to set up a Center of Excellence, it's in the order of $3 million to get the thing off the ground. So we've got a long way to go. We feel we've started. We've got our teeth in there, and we're excited to expand, and we're excited to raise more funds through donors and sponsorships, and we're in fact looking for them right now.
So hopefully this is helpful, and maybe some ears hear this information about that, and that can help move you forward. Question: Where's the funding come from now? How do the people that come to get your services?
Right now, the medical services are covered. The government covers that because they're all covered. But they don't cover any of the other services. They're basically through insurance companies or private payment to that. But we're relying on sponsors. We've got some beautiful major sponsors right now. Tricar is one that's been helpful to us. They're a building group in town, and they've been wonderful. We have Sun Life is involved. We got McCormick's involved a little bit. We have the Ray Foundation involved a little bit. So we're pretty excited about some of the people that we've had. And we've also had VersaBank involved. So we're trying to get more sponsors. If they roll in a little, we want to get them to the party on October the 30th. It's going to, our fundraiser is going to be not your ordinary fundraiser. We're going to have a music concert featuring music of the Beatles and the Eagles, and it's going to be a fun night.
Cool. Super excited about all of that. You know where you're going, don't you?
Oh, he does. And he's missing part of it, though, which is his biggest dream of all, is that one day every university in all of Canada will also take on this model.
Wow.
That's
Wow.
Yeah.
It's shoot for the stars and see what shakes out, right? Because you never know.
You got it.
Yeah. I know that the funding is often a barrier
Yes.
for many in trying to figure out how those things go. Is it safe to assume that you're a not-for-profit if you're doing these organizations?
Non-for-profit. We've been since basically for the last 25 years. And so it's very managed, controlled. We are trying to solicit funds through various organizations, including the government. We're trying to say if we couldn't have some sponsorship through the government, even on a 50-50 basis. You forward 50%, we'll raise 50%. And we want to make sure we help those that can't afford it. So they don't have the insurance. We want to be able to include everybody.
Of course. Are you involving students and placements and co-ops and education into the process as well?
We are. I'll let Sarah address that.
There we go.
Sarah, she's right in the midst of it.
Yeah, right in the middle of it. So I actually did just have a meeting with the nursing program about a month ago. So we're looking to launch having students next summer for the nursing program. And we do have already a dietitian intern, and I think we'll be taking residents hopefully shortly as well. We just have to finish the paperwork with the university. So we are right on track.
Amazing, amazing. I see the value in knowing that you have this long-term goal and this modality of care, that when you include the leaders of tomorrow into today's stuff, you never know where it can go.
You're right. To include them is so important to them, and we're trying to bring them into fold. And I think they are learning a lot. And the other side of it is working with those with lived experience to be able to include them in terms of the outreach and doing it with caution, so we're not precipitating, symptoms all over again. But we're monitoring it. But they have a great deal of value in helping others, reaching out, and those that are in need of support gain a great deal of, I think, camaraderie with those that have been through it.
Without a doubt, my profession in the addiction world, lived experience is paramount. It's really important, and it gives a sense of safety and the capacity to be able to move forward and trust a program to happen. So lived experience is vital.
It is. You've said that well. That's dead on. Yeah.
Wonderful. I'm glad that you're including that in. So it sounds like you have all the bases covered and you're going in the right direction. I have some questions about, you say that it's been around for a year now. Where'd you both come from before that? How did you get here? Because Dr. Campbell, starting a new business, is a big undertaking, and we don't always do these things unless there's some real passion behind it, and it depends on what's going on in your life. So I'm assuming there's some catalysts that made this a passion and a purpose to jump into. Am I wrong?
No, you're
right.
absolutely right. So I've been after this since 1967.
Wow.
And so it takes this long to try to get this far.
Yeah.
And I've tried numbers of different things to try to go through. I've always had a passion for eating disorders. And people often say, well, why are you focused on eating disorder? I was raised by a severe diabetic mother.
Oh, okay.
So food was always on the table. She'd be called off in the middle of the night, sometimes to the hospital, not knowing if she's going to return. We feel that we didn't eat our peas, and she overreacted and took chocolates. So the whole thing was diet focused.
Yeah.
And although she didn't have a bona fide eating disorder, it is often equated with the diabetic population.
Sure.
Even those that the juvenile diabetics, it's equated with it. It's well known. And now that we're looking at the pre-diabetic and the diabetic population, the incidence of binge eating disorder is there, and the form of anorexia in a diabetic. So that's where I gained my big interest. But all through my residency training program, I had worked with endocrinology, I'd worked with neurosurgery, I'd worked with a whole bunch of different what I call them fringe medical kinds of things. They think psychiatry is fringy, but I think all theirs is a little fringy. I work with transplant teams. I've worked with bowel resection, gastric, all these kinds with analysis through the years. Okay. So I've done a lot, stuck with it, and have always been, but never had the opportunity to try to set something up, because out there right now, they don't have this program, if you get referred, it takes up to a year to get assessed, and it takes another year to get treatment. So this is not working at all. Sure. So what drives me is that there isn't anything out there. There's no support out there. Where do you go? Yeah. And the other thing is, if you're a student coming from anywhere in Canada or outside of London, what do you do when you're in town to try to keep you involved in school? So you stay here. We're also trying to keep people out of hospital. Right. So we're trying to, and we've also picked up a few people that have been just discharged from hospital, so they have a support system to go to when they're discharged, so they can be discharged. Yeah. So we're trying to work into the business model, I suppose, of medicine to try to help out where we can.
Sure. So in essence, Dr. Campbell, you're also lived experience, and those lived experiences carry forward. And what I'm hearing you say is you spent a very, very long time pulling people out of the river, and now you want to prevent them from falling in the first place.
I'd love that. I wish I need to capture that.
You have it on camera.
Yeah. Beautifully said. Yeah. Beautifully said.
Wonderful. And Sarah, a year ago, you decided to jump into the waters of the harbor.
Not even quite a year ago. It was sort of by fluke. Yeah, Dr. Campbell and I just bumped into each other in a hallway, and he said, "You're a nurse that works in eating disorders. You happen to be moving to London, so jump on ship with me. I have a new project for you." And I said, "Let's do it."
Share with me your interest in working in eating disorders in the first place, and your being a nurse.
Yeah, so I also went to Western.
Okay.
I spent 1 year living in Kitchener, doing general psych for more long-term mental health, and then stayed there when I moved to Mississauga for another 9 years. While I was in Mississauga, I had the opportunity to work casual on an eating disorder inpatient unit, which also gave me opportunity to work with the outpatient department as well. So I've been with them for the last 10 years, and then my husband moved here for a new business, and so I said, well, I need a new job. I can't keep driving to Mississauga, and
and your job found you.
Exactly.
Lucky me, lucky us, lucky eating disorders. We're very fortunate to have her. It's just amazing.
Wonderful. Now, you had talked about all of the different disciplines that, you see the value of bringing those things all together. Is there a specific modality or anything specific in the work that you do in the bringing them all together that is unique, or I know that you have a lifetime of working in the field. Is there something specific that you do that might be different or sets you apart from other organizations?
I think maybe trying to help coordinate it. We're trying to work too with the family physicians. Okay. We're trying to work with the family health teams out in the community. We're trying to bring the factions together. I think we're looking at ourselves as a bit of a catalyst, or to help navigate the system, because it's very difficult for everybody. And they are not the services out there that we think there are. So our role, I think, is to try to bring the disciplines together so that we would, for instance, have meetings. We share the record, share the note. So when it comes in, they want to be able to share this therapist with that therapist, with this, whatever they need, and with the family doc, so we can coordinate the physical status with the mental status at the same time. See, the object is, I think our role is taking a leadership role in trying to coordinate the team. Maybe it's a coach.
Awesome. Awesome. And I say awesome because maybe people aren't aware in the community that the silos or the compartmentalization of medical care makes it so that we don't share and communicate. And then you have individuals who are going to get help, and then they're talking to 5 different individuals and getting 5 different opinions and different ideas. And then it's counterintuitive care against the individual then becomes the wishbone of the party. And then they feel lost in the middle, and it can be more harmful than is good. So what you're saying is bridging some of those gaps in the way that we collaborate, but there must be barriers to that.
Well, there are a lot of barriers, because you have summarized exactly where the issue, that is the issue, the silos. We're trying to break down that, and the silos also between the hospital treatment and community treatment.
Yeah.
We're trying to bridge the gap so that people are working together in collaboration to make it better. So there are a number of difficulties in this, because everybody is still sticking a little bit to the silo, but it's starting to loosen up. I think with us being in there all the time, I think we can get the community to work with the hospital, hospital work with the community, work with the university, work with the colleges, etc., and say, look, we're all in this together. We're trying to help people get by the best they can, especially having been through the last few years that we've all been through.
Sure. And what I would like to share with the audience at home, it sounds like a simple concept, but once you employ insurances and the Personal Health Information Act and other things that come into play, sharing that information becomes a liability, and many people are risk averse. So professionals don't want to share that information at risk of ruining their own career or their own business. So there's a lot of barriers there when it comes to those things that the average public doesn't understand. Well, why don't you guys just talk to one another? I get mothers calling me, can you tell me about my son? No, I can't. What son? I don't even know. What are you talking about, right? Right? So there are barriers in that.
And those are barriers. There's no question about it.
Yeah.
No question.
So it takes a little bit to overcome those things, and it's not easy. We have a couple of minutes left, and I'm going to go off of the script. I've loved everything that you've said here today, and I'm super grateful for the services that you're providing, and I can't wait for this to come out and we can share it with the community. But I was wondering about in my work, I just mentioned it, very often it's the family members that are reaching out. It's the individuals and loved ones who are struggling. And I'm sure that throughout advocacy, you've got, going up and talking about it as somebody comes up and says, my son, my daughter, the person. And we know that this is more than just the individual. It's the family unit that's being impacted. And you sound like you have this wonderful holistic approach to everything. Tell me about the services that you provide, or how you redirect family members.
Well, you mentioned families, because often if someone's coming off to university or college, the family is involved.
Yeah.
Because this is a period of transition, moving away from the family, moving out on your own. And the other thing is you're moving from different treatment models.
Right.
In eating disorders, invariably use a family approach up to the age of 18, but then they're cut off at the age of 18. They're not seen by anybody. And the adult programs don't have the family approach. They want to move away from the family. It's not one size fits all. We have to be able to accommodate this transition period, and people really haven't got it yet. And this is the group that we're dealing with right now at university and college level.
Yeah, we see that disconnection, lack of connection has a lot to it. So when you start bringing it into a bigger, like I had said it myself, I'll quote myself, the village, right? Then it provides a sense of community and connection. So this has been wonderful. We're at a time. If you can say one quick thing, just what would you tell the viewers at home about taking care of eating disorders?
I think just learn some of the recognition signs, even from age 3, 4, 5, and 6, when sometimes they present.
Okay.
Let's pay more attention to our eating healthy, exercising healthy, and having a healthy lifestyle. But listen, if a person does appear to have some issues, make sure you seek some help. Make sure you seek a little bit of support.
Awesome.
I don't feel it's wrong or you've failed or anything like that.
Awesome. Thank you so much for being on the show. Thank you for watching Stirring Strength. We'll see you next time.